In 2018, the Syngap Research Fund, and quickly we've grown our organization to a board of 14, and we have lots of volunteers. That's a really patient-driven organization. We are very much collaborative, and really in our our statement is urgency, collaboration are really big for us, and so. We're one of many, and I think in a very competitive market, when you're looking at, companies that are looking for, when you have disorders that are looking for treatment, companies are always weighing who they're going to work with, and we've really worked really hard as an organization to set ourselves up to be able to be very much ready for clinical trials, and we'll talk a little bit about our journey and how we've worked with combined brain that are other gene disorders that are collaborative. We work with researchers trying to really fill the gap of research that federal funding may not fund, and so we're really grassroots in being able to raise money to be able to fund that, to fill that basic science need. We work really hard in clinical trials to be able to find end markers, and so we're funding and working through organizations, through Duke, a program called ORCA, which really was driven by Angelman syndrome, to be able to find programs where we can actually have end markers for our disorder. Sleep is a big thing. Epilepsy is a big, almost nearly 100% of our patient population has epilepsy. And so research into identifying those as clear biomarkers that would allow us to evaluate treatments is really where we're at. And Mike will talk about this quite a bit, but we've invested into really clinical trials. You need patient data, and so we'll really talk about our patient data-driven journey in order to be ready for a clinical trial. And in fact, recently, SCN2A, who's working with Praxis, the FDA accepted a digital natural history study that we currently have almost 200 patients enrolled in. We have all of the medical records from nearly 200 patients in a database. And working with Invitae Citizen, they've gone through and they've basically analyzed the data and given a very clear profile of each of those patients through AI. And genetic counselors reviewing that, and a medical team reviewing that data. In fact, the FDA accepted that database for clinical trial, which is a very big deal, because normally you would have to go to an educational institution who would have to collect all the records and do this huge exercise in trying to get the natural history study developed. And we actually did this in less than 2 years, where we're preparing for clinical trial. We're currently in pipeline for approximately 3 to 4 drug companies, which is exciting. Dravet being one, SCN2A, and a couple of others. So we're really in deep conversations and really putting all of the pieces of the puzzle that the FDA really wants to see in line to be able to prepare ourselves for a clinical trial. And we'll give you a really in-depth kind of a look at that and what our journey's been like over the past, since 2018, when Mike and Ashley were diagnosed, and I quickly began working with them and on this journey to try to really make an impact for our kids. And again, one of our action items is, besides collaboration, is urgency, right? And so we're working really hard to really put this together. But again, we don't do that in a stovepipe. We really work hard in collaborating with other genes and other organizations to really pull this together to be able to make this happen in a much accelerated fashion. So,
cool. Thank you, Aaron.
Yeah.
Hi, I'm Mike. I set up the Syngap Research Fund 4 years ago. There's 4 people in here. Do you guys want to tell me, if you have questions and who you are, in case I could, because I could talk about SRF and the work Aaron highlighted for hours. I've been doing this nonstop for, my son was diagnosed 4.5 years ago. And I think what SRF has done is pretty impressive. It's better to be lucky than good. I think in a lot of ways we got lucky. But we also done some hard work and learned a lot along the way. So, you know, I'm happy to answer questions. Do you guys mind if you just tell me sort of who you are and why you're here? You guys want to know?
Yes, our daughter has KCNE2. My name's Alicia, which is Gwen.
Yeah.
Our daughter has KCNE2. And it's very rare. There's less than 100 people worldwide diagnosed with KCNE2. But we did start we didn't start, someone else started a Facebook group.
Yep.
Which then gave way to us starting a website. And we got a natural history study going with the scientific team from Philadelphia University in Denmark.
CHOP? What CHOP?
No, Philadelphia with an F in Denmark.
Okay.
Oh,
Okay.
yeah. Rike, I know. Yes.
Rike Moeller is involved, and
She's great.
Stephen Serby,
Yep.
all those guys. And we're just interested.
And how old is your little girl?
She's 5.
And when was she diagnosed?
When she was 2.5. So 2.5.
And with KCN?
With KCNE2.
A2, is it a life sentence? I mean, is there a risk of her passing from her disease, or it's a
Not
life
that we
sentence?
know of.
Yeah.
As far as we know, one person with KCNE2 has passed away.
It expresses itself all over the place.
It's a huge
Yeah,
spectrum.
so,
In terms of, my daughter has gain of function. There's also ones with loss of function.
And it's a missense?
She what?
Her mutation is a missense? You don't know.
I don't know.
Do you have her genetic report?
Not with me, but I have.
What does that mean?
It's just interesting. It's a specific type of mutation, but if you have the genetic report later, I can look at it and I can help you figure it out. It's important to understand. And I say I'm on the record. Like I have a podcast, and I go off on this about every other month. If your child has a genetic disease, you like literally. And I said this as a joke, and I think right now 2 families have done this. You should tattoo that mutation somewhere on your body. Like you want to know exactly what that mutation is, how it works, and why it's deleterious. So yeah, okay, let's keep going.
I'm Viet Nguyen. I'm a neurologist with Biogen working in clinical development for neurodevelopmental diseases.
Yeah, I saw you at the Pipeline Conference. You had a really nice suit on. It's like that's a well-dressed neurologist. I remember you. I mean, you were on stage, right? You presented about the
Yes.
trial. Yeah.
I have a rare genetic mutation, SETD1A.
Okay.
So, and I have Jabon syndrome, and apparently it's not even one of the common 6 genes that is in Jabon syndrome.
Right.
Jabon syndrome is a rare epilepsy.
Yeah. It's a lot of lumping and splitting that goes on.
Yeah.
And you, ma'am?
My niece and her mom just lived with her other daughter.
Yeah.
She is 2 years old and she has KCNT1.
Yep.
And so she was, when she started having seizures a week or 2, maybe even early right after birth. But this is our first year here. I'm here supporting them. And
And she's how old?
she's 2 right
And you're with Biogen, right?
Correct.
now. But I just texted
Yeah. I got it. So Justin West is the other dad who's supposed to be here. Justin is a surgeon, and unfortunately he's not here. So if you're just here for KCNT1, I won't be hurt if you leave, because Justin is the better-looking, more successful version of me. He's a good guy. What I would tell you, though, like, so it's largely just through the lens of what we've done at SRF, and if you guys have questions, ask. I think one of the questions that people come up with, especially people like you guys, is like, what is this advocacy thing? Do we make a difference? Should I bother? I think these are really basic and important questions, because you come to these conferences, like, it's clear what the biotechs are doing, you're making drugs, it's clear what the doctor's doing, they're treating patients, it's clear what clear what everyone else is doing, they're selling something, and you're like, why are we here? Like, what is our role? And I thought that in the beginning, but for me, I thought our role was to raise money and fund science, right? I really thought that was it, and I think raising money and funding science is really important, but not for the reasons that I thought, right? I think it shows people that you're serious, and it gets people to pay attention to you. The amount we've given away, we've granted, this number keeps changing because one grant just evaporated, but call it at least $3.5 million in our 4 years, right? That's enough money that people are like, oh, they're serious. And that access to the scientific community, and like we're gonna, for those of you going to AES, we're having a meeting on December 1st about everything we've done, and that's been really, that's a real accomplishment in terms of what we pulled out. But I think the important part of patient advocates is to collect the patient data. As Aaron mentioned, we have partnership with Citizen. We have a registry. That data has been licensed by multiple pharma companies at some cost to them. And so, this tells everybody that they're serious about our disease. And the reason they spent money on that data is because it was cheaper than if they'd done it any other way, right? And that's only possible because we as the patient community were organized. Because Aaron was one of the first leaders who took me under his wing. And then my wife and I built this organization. And through that organization, we were able to create the most valuable data set in Syngap 1, right? That's powerful, and that's accelerating therapeutic development with some companies. And then the other thing we've done is just, if you think about Biogen, or just pick my name because you're here and you're clearly labeled, but any drug company creates a therapy for a disease, like KCNA2, and they then have to find patients, right? And if those patients are hidden or hard to find, companies will spend if the company develops a drug, they will then have to spend real money on it. But if the company feels like it's really going to be hard to find the patients, although, Syngap 1 is the only gene I could spell for the first 2 years, the truth is drug companies have a list of like hundreds, if not thousands. And eventually that becomes a list of 10 and then 5 and then whatever. But those companies are just one of the variables. Please correct me, doctor, if you think differently. One of the variables that they consider is, am I going to be able to find patients? Are the patients organized? Can we connect with them? Do I even have enough trials in markets that matter where I can do a trial? And so that, I think, has been a huge part of the work. So I don't know how big KCNA2 community is. But I would urge you as parents, especially if someone's so young, to keep building it, to keep growing it, and to keep pulling in more and more families. Because, I publish a count every quarter of how many patients have Syngap 1 in the world. It's about a little under 1,200 worldwide, a little under 400 in the US. But I know that number is a subset of what's been diagnosed. And I know what's been diagnosed is a subset of who could be diagnosed if we just tried harder and more people were aware of Syngap 1. So this work is thankless and lonely and tiring and very little fun. And I could probably go on. But it's worth it because we need a therapy for our kids, right? And the only way we're going to compel these incredibly important and powerful companies to invest in these therapies is by making our community as clinical trial ready as possible. And that's kind of the lens. Like, if you have a bunch of money to throw at science, or if you don't, it doesn't matter. What matters is that you're beating the drum, you're wearing the t-shirts, you're meeting other parents, you're helping other kids who are diagnosed feel connected enough and welcome enough to join the community, because the only way that my son and your daughter and anyone else's kid is going to get a therapy is if the companies invest in our community. So we have to show them, not convince them, not make them believe, but actually show them that there's a community there that's going to receive that drug. And that's kind of what drives me at this point.
Yeah.
I think the money we throw at science, if we're smart about it, is occasionally helpful. And I think the experiments I do think we're bringing things forward faster. But I don't think patient advocacy is about money. I think it's about unifying the community and getting the community clinical trial ready.
Yeah, because when I first met Mike, in 2017 or 2018, he was like, I'm not worried about basic science. I don't care about databases. It was about treatment. And I've watched him and the organization really evolve to where federal funding is not going to fund every aspect of the basic science, and we don't have enough. There's not enough interest in basic science, and there needs to be. We're so in our infancy of molecular biology and how the body's working, and all of these things that are happening, the interaction of these proteins and the neurosystem and in the body are just so complex that we have things to figure out. And I think what Mike's alluding to and understanding the variant type, whether missense or nonsense, is because it does make a difference. I mean, a nonsense mutation is probably going to be an easier variant to kind of work with over a missense, which we have. But I think it's understanding your science of your genetic disorder to be able to know how you advocate from gain of function, loss of function, and what those strategies are going to be. So for like us, we're all haploinsufficient. So it's going to be what's the strategy to upregulate the good gene and what's that mechanism going to be, right?
Yeah, and for KCNT1, for instance, just to put Justin's hat on, most of their mutants are missense. Whereas you are, and are you a missense mom? You're a KCNT1 mom? Yeah. And your kid has a missense.
Yeah, and like my son's a missense, right? So I have a point mutation, there's a glycine, and it ends up being a serine, and it's in the C2 domain, which is a primary functional area of the Syngap protein. And my son is mod to severe. But again, we don't, missenses are an outlier because if I'm going to try to upregulate the good protein, likely because both, in a missense, you're creating both proteins, both good and bad. Where nonsense, you're creating more of the good. The bad really does go away. The body clears that out. But we don't know in the science. There's not a lot of science that can really tell us like what's going to be the impact. And so we work to fund some missense research because a lot of the initial research was all on nonsense, and a lot of research is driven on nonsense because it's a simpler...
In Syngap 1.
In Syngap 1.
In the KCNT1 community, it's a lot of missenses, which is why I asked about the KCNA2. I assume you potentially the same. And what I would say for the families in the room, I mean, KCNT1, Sarah's over at the table. I assume you know her. You need to talk to her. She's great. But what I say to anybody, and I did it, you did it, is if your child has a mutation, the first question you ask is that mutation studied and modeled, right? Is there a cell line? Is there an organoid? Is there a mouse? Like, and everything I just said, you go up like a digit in cost. But you can make a cell line for like 10,000-ish. And if you can get that cell line into a lab, it's worth it because, especially for missenses, because different companies and Biogen will probably do its own analysis, find its own patients, and make its own cell lines and organoids. But a lot of biotechs out there, and I know this because I live it, are like, yeah, we have this thing, we think it could work on Syngap, and I basically open my trench coat. I'm like, I have 10 cell lines, which one do you want? And they're like, I want that one, and that one. And I call somebody and they FedEx them. And two things just happened. Number one, I just saved that company 6 months because making a cell line requires, especially for a neurological issue, it's tricky, right? You can do a skin punch and move a little faster. Some people prefer blood, but it's a 6-month-ish process from blood draw to cell line, and then it's a few more months to stem cell to neuron. So, but neurons don't ship well and iPSCs do, so better to make the iPSC. But what you want to do is you want to make sure your child's mutation is available for study. And the first thing I did, because I generally do things backwards, is I spent 6 figures on a mouse for my son. That was 4 years ago. That mouse is going to be published like next month. Thank God. But what I should have done, if I had been smarter, is spend $10,000 on a cell line. Actually, I did that too. Now I think about it. But I didn't do it the right way because I did it with a university. And when you make, let's just pick on some universities for fun. If you make a cell line at Baylor and then somebody at Hopkins wants it, Baylor and Hopkins will play nice together and they will ship it. If you make a cell line at Baylor and then someone at BioMarin wants it, Baylor will show up with 5 people who just got out of law school and weren't smart enough to get into a firm, don't have children, and will sit there and waste everyone's time arguing about why Biogen could not have this cell line because they have to protect patient privacy. It's complete and utter bullshit. And I have lost my mind on somebody who actually had the audacity to tell me they were protecting my son from me as I was trying to get my son's cell line into a company. That person may never recover from that meeting. But My point is, if you're making point one, make a cell line for your kid if they don't already exist. And B, make it with a private commercial entity that will do as they're told, right? If you make a cell line with a CRO, a contract research organization, and Sarah will know people, and you guys, your advocacy group will know people, and if they don't have them, call me. But like, make the cell line with a private player, and make sure you own it, because frankly, there's no IP there. It's a cell line based on your child's DNA, and give it away freely to people, including Coriel, and I can talk about this for hours. But you want to make sure your child's cell line is available for study, because we as families are even wealthy families are not going to be able to raise and spend enough money, except for like the super wealthy, to really change the history of study on that disease. Like, science is happening. People like Dr. Viet or Dr. Newton, Dr. Wynn, people like Dr. Wynn and companies like Biogen are going to do this work. The way I have come to think about advocacy is it's our job to make it easier for them to work on our gene, and selfishly to work on our children, right? And every smart advocate I know, and I count Aaron and I in that number, I can tell you exactly how to get my son's cell line in your lab on Monday. Like, if I meet a scientist and they want to work on Syngap 1, I'm like, here's Tony's stuff.
Yeah. And I think another way is, like, if you're a new organization, you don't have a lot of money, but let's say you have your gene has an association with autism, like, then we've partnered with Simon's Foundation. They work with the single genes that are associated with autism, and they actually do have the ability to add cell lines, iPSC cell lines, that they can make readily available to researchers. So I would say, if an organization doesn't have the resources, I think partnering with some foundations like Simon's is a great organization to collaborate with, who will give their cell lines, give them up freely to any researcher. Again, they're investing into this because, again, they have a lot to promote in the autism.
But they won't be fast.
Yeah, because they're going to go through.
Yeah,
right,
science is going to take 1 to 2 years to make your kid's cell line. You can get someone to make it in 6 months for $10,000. Yeah. Like, find the $10,000. That's my answer.
Yeah. So when it comes to the cell line, is it better to have more, like, for example, focusing on the KCNA2, getting as many people with KCNA2 to do a cell line, or like you only need one person to do it?
Well, let's go back to missense versus nonsense. That's a really good question. The answer is every missense mutation wants its own cell line. Like, I'm literally talking to a researcher. So in Syngap, I have 1,200 patients diagnosed that I know about right now. 66%. So 800 of those 1,200 patients have a nonsense mutation, where your child has 2 copies of every gene, one from mom and one from dad, right? My child has 2 copies of Syngap, one for me and one for my wife. One of them, probably mine, is defective, right? Because it's nonsense and because it's defective, like 800 other patients in my community, that bad copy, this is a little oversimplified, but basically true, is incomplete. The body is really good at seeing the end of a protein. It's called the 3' end. And when the body doesn't see that, the body says problem and just chews it up and spits it out. It just recognizes it as an incomplete product and trashes it. So 2/3 of my diagnosed population have a nonsense mutation, meaning they're all the same biologically. They have a good copy and not enough. Aaron's child and another 20% of my population have a missense mutation, where that mutation, the arginine to the glutamine, is misfolded, right? So one Lego block in the chain is the wrong shape. And because it's misfolded, it's probably out there breaking stuff because it doesn't fit. Even worse in the case of Syngaps form trimers, which means 3 copies of the protein form together. So that one bad copy could be sucking up 2 good copies, and then they could all be being useless, right? But in the case of each missense mutation, the misfold is unique. So if your child, and if you had the same gene, at KCNT1, most patients have missense, right? So you basically want to model, if I'm Justin, and I assume he's done this, you want to model for every single missense mutation. So as your daughter's parents, what you want is definitely a model for her, and you want to go and figure out where the cheapest, fastest place to make models is that is still high quality. That last part's important. And then you want to encourage every family to make a model. And in the grand scheme of things, it's time versus money, right? Like when I figured this out, we agreed to make, I think, 6 lines. And we chose those lines on a variety of genetics, doesn't matter. But what you want to do, and I don't know your gene, but I assume you have different domains. At the minimum, you want to have a couple things from each area, but ideally, step 1 is to do the registry. Step 2 is to figure out, okay, what's everyone's mutation? Any common mutation, you want those. Because that's what the drug company's going to want, right? If there's some random kid like mine who's got a really weird mutation, they're like, I don't want that. Because that kid's weird. Like if you've got a population and 10 kids have this mutation and 6 kids have this mutation and 4 kids have this mutation, those are the ones they want. Now since I bothered to get my son diagnosed and put him in the literature, I've now found 4 more patients. So he's no longer weird. But the other thing to understand about all this genetic stuff is we're still at the beginning. Like it's so early days. And by spending the money to get that cell line made and making sure it's available, and then advertising it, like you're here, you're doing the right thing. You want to go, and you basically, it's like, you know the deal. Google Scholar, find the papers. Don't call the last authors, they're important. Call the first authors and ask them who their postdocs are. And call those postdocs and be like, hey, do you want a cell line? Like you're literally like a drug dealer. Like, anyone want a cell line? And just, because that's how, no one's going to say yes for fun, right? But if someone's working on something, and the other thing that I've observed is changing is when I began, I was working with people who worked on Syngap. And the most recent grant we gave to a guy named Jeff Collar at Hopkins. Is it Hopkins? He has a technology that basically fixes a certain letter change, right? At the RNA level, if you've got a C, he can change it to a T, or it's a J, I don't even remember. But if you've got one letter, he can change it to the other letter. So he's not even trying to cure Syngap. He's like, I just want to see people with this kind of mutation. So we're like finding him, and we had 2 cell lines, and we sent them to Jeff, and Jeff's working on it. And if we didn't have those cell lines, Jeff would be 6 months out. So that is the smartest and probably cheapest grant I've ever given, is to make those lines.
So,
Please. Go ahead.
We think there's 15 of us that have that arginine to glutamine change in stain 1. So would you recommend just 1 cell line for the 15 of us?
2's better, 3's better, but start with 1.
Okay.
I mean, and the other thing is there's no better way to get people to spend money than to lead. Like definitely you want your daughter's genetic, because there's 2 ways to make a cell line. This is important. You can take your daughter's blood and grow it into an iPSC, and that will have all of her genetic background. And for experiments, that matters, because what you're really after is something you can put into your daughter to help her address this disease, right? So all of the genetic background there is best in class. What's cheaper and slightly faster is to take a healthy neuron and CRISPR in her specific mutation. And some would say it's better from a scientific point of view because they already know how that healthy neuron behaves. So with that mutation in a healthy neuron, they're going to know exactly what that mutation caused. I would say 6 of one, half a dozen of the other. Some people would say just do both. But I would start with yours and go from there.
So is it in the exact same location?
It's the exact same mutation.
It's the exact same mutation. That protein change in the exact same location for those patients? Because if they're in different locations, then we would say you probably wouldn't want a cell line for different locations.
All I know is that C890G
Yes.
to A.
Yeah.
It's the same.
It's the same. If it's
Those are
690,
the same.
They'd have to have,
If
they'd have to have some
if the
deep
690 is the
registry to
same,
be
yeah.
able to know
If
the
The
other.
numbers, the address,
yeah,
the beginning and the end letters are what it was and what it changed to.
yeah. So is the,
Yeah,
that's-
there's 15 of us with this variant.
exactly.
Yeah.
Okay, good.
That's your
Yeah.
answer.
Because we have 9,
Yes.
for like my sons, we have 9 in the world, which is crazy. Through Facebook, we all found each other,
Yeah.
which is amazing to find 9 people with the exact same mutation is just
Yeah.
crazy.
In our population.
I know. For us, it's crazy because there's less than 100 people worldwide, and there's so many different variants. But there's 15 of us with this one.
Which goes
Definitely
back to,
build that line.
Which goes back to evolutionary biology and how certain genes are conserved versus not conserved, the vulnerability. So there's a lot of science that goes into the biology of that, which is fascinating.
Aaron and I have different takes on this. I think it's luck.
Yeah.
I think especially I think you resolved the bus early, and that's why they found one. But we could debate that for hours. Sorry.
With the private CRO approach to making cell lines, are there economies of scale if you work together and bring up more lines? And are there sustainability issues with maintaining that line over time?
So,
do they change the price on you?
So yeah, my first answer is yes, but not in the ways you think. And my second answer is sort of. So once you get a line, you can give it to Coriel. Coriel will charge scientists and companies to take a line, but they'll charge them like $1,000, which for them is like a rounding error, like whatever. They'll pay $1,000. So what I'm doing, I made 6 lines with a CRO, and we've done such a good job with biotech engagement that the CRO who I'm working with that has my lines is like, Mike, we're so sick of filling these orders. Like, this is too much work. So we're now working to give all the 6. We made 8, and by the way, they don't all work. They don't all work for a bunch because science is strict, right? So we made 8 lines. 6 of them are viable. 2 of them people are still working. So we're giving all 6 of those lines to Coriel. So people can just look them up and pull them down there. So I think it's sustainable because once you make them and they've passed QC, you can give them to a Coriel or some other bank, and they can just be out there. I think the efficiencies are, the cost efficiencies of doing it through a foundation as opposed to as a family are foundations are nonprofits. You can ask them to waive overheads. You can negotiate price more credibly. But also, if you do it as a group, you're going to there's just a lot of management and headaches. Yeah. Like we as normal. I'm a math major who did finance. Right? I can't spell any word of more than 5 letters. And so for me to be playing in the science space is just really fun, if you think about it. Yeah. And so me negotiating with the CRO to make what's isogenic pluripotent stem cell? I can't even spell that, right? And for me to be doing that is ridiculous. And I think that one of the biggest cost savings is management. Once you find another organization who's done this before, and you build a relationship with somebody who can make it, then you can negotiate pricing. Because if you're just walking off the street and say, hey, I'm a parent, I want to make my kid's cell line, any good salesperson is going to throw a number that's triple at you in case you say yes.
So I could use that as a segue. So again, Coriel I would agree with, because I work on the clinical laboratory sciences, and we were validating spinal muscular atrophy, and we're getting ready to do cystic fibrosis testing. We ordered cell lines from Coriel so we could do our validation with known mutations within there. So I agree. I mean, Coriel's a way to go for housing it because people are going to look for them and pay for them all the time. I don't want to piggyback off Mike's discussion about knowing where your population is, because we worked really hard. Dr. Hans really worked. He's one of our family fathers whose son, and he's an infectious disease physician, so he understands ICD-10 codes, and he's been working on this project for a really, really long time. And while you can be on Facebook finding each other, that's great, and you can talk about my kids like this, my kids like that, but we've worked really hard as a community in order to get an ICD-10 code, and we're working on 11 because really when it comes down to tracking your disease, your disorder, and getting it visible to the larger, at a federal level, because that's what the ICD-10 codes, and actually from an international perspective, right. Really you really want to fight. And I'll tell you, the system is really, really broke from the respect that we have gene disorders that are happening that get these very vague codings, and we're for the insurance companies and right? I mean,
coding wasn't built.
Right, and so it really hasn't. Right, it hasn't really been built.
But do you have one for KCNT1?
No, we don't.
But would you like one if you're going to roll out a drug?
Yeah, 100%.
So it's not built, but we need it. I mean, it's.
And he's actually proposed to the CDC a very clear algorithm for how rare diseases could actually be coded, then we would all know.
But what I tell people, Aaron, is don't even waste your time on ICD-10. Like that's become a hill people
No, because 11's on the way, right?
I would 10 years out, but we got an ICD-11 code in months. We took us 2 years to get an ICD-10 code, and now the trouble is, we got lucky. Aaron was very complimentary of Hans, who was a friend, but he's also a pain in the ass. And I think at a certain point, the CDC just wanted Hans to go away. They can't give you the code.
He was persistent to no end.
It's a nice way of saying it. And now what you're seeing is like, I can think off the top of my head of like 10 other rare diseases that are fighting to get an ICD code, those battle lines it's hard. But and the things, now that you've opened this box, ICD codes come from the WHO and go to the world. ICD-10 is live, so you have to go to the CDC to get an ICD-10 for the US. ICD-11 is coming from the WHO, and the way to get it all over the world, especially if you have populations in other countries, which I think we all do, is to go to the WHO and get it into ICD-11. And they are much more reasonable and they're much more reasonable than the CDC.
But when it comes to federal funding, does that need to run through the ICD-10?
No. It just helps from an epidemiological perspective of disease tracking. And
if you've got limited time and resources, I would not fight that.
Yeah, no, it's a kind of an aside. It's kind of an aside fight.
Aaron is
It's a coding system built up for insurance companies to bill properly.
Yeah.
It has nothing to do with patient care.
Yeah, no,
it does help find patients. I mean, I'm glad we have one. But
We can leverage that ecosystem when you look for epidemiology. Like I can query everything that's been billed with that ICD-10 code, but it's again through the billing and insurance system.
Right.
So for common things like heart attacks, it works super great.
Right.
For everybody that's in this building.
No, it's not a fight I fought. It's a fight Hans took on, and I'm very glad to be proud of it. But I wouldn't spend your time.
But we use it on everything. Let me just tell you, it's on everything.
It's on your shirt.
Or is it on?
It's not on the shirt.
Let me
the next shirt it'll be on.
It's
So
on
back
everything.
to the cell lines. We took our daughter's cord blood when she was born. Is that something that's going to be? I don't know if you know, but
I don't. That's science. They're probably going to want fresh blood. They're probably going to draw 3 vials of fresh blood and just send it to a lab.
But they're after the white cells, and the white cells and being in both sides.
Yeah. You said 100 patients worldwide?
that we know.
Never know.
In which countries?
Spain, South America, I don't know the continent, but Australia.
So if you guys Google Syngap census, like Syngap, SYNGAP census, one word with a hashtag in front of it, you'll find all the articles I've ever written on this. If you go back to the first article, I literally just put up a blog. And I was like, I think because what happened is we were diagnosed, and I asked someone how many Syngapians, 1 to 200. Mm-hmm. And then I saw on the Facebook group every week another family.
Yeah,
And
it's
then
like that in our Facebook.
Right, and then I said to somebody a year later, how many families? 1 to 200. I was like, well, you clearly have no idea what you're talking about. Because I've seen at least 50 people. So if you knew what I know, you'd be saying 150 to 250. So I don't trust your first answer or your current answer.
Yeah.
So I basically called every country leader, and I pulled the mailing list, and I went through it, and I was like, I think there's 384 Syngapians. I didn't name them, but I did say Argentina, 2, India, 0, China, 0, which doesn't make any sense, right? US, and I listed it by state. I said Wisconsin, 4, whatever the numbers were. And I published that on our blog. And I said, the only thing I'm sure about is that this is wrong. It's too low. And the number wasn't 384, it was like 27, whatever. Yeah. I got an email every day for the next 3 weeks. Mike, there's at least 5 in Wisconsin. Mike, you missed 2 I know of at least 7 in the UK. And the numbers kept going. And basically someone needs to keep that list. And now, thank God, I still have my job anymore. Jess does it. But that has been a really useful exercise.
Yeah. And
it's also great. Industry likes it. I've seen this number in corporate presentations because they're like, wow, okay, so there's at least that many. Like if Mike knows about 1,200, we know there's probably at least 2,000 diagnosed in the world. Yeah. And we know there's 20,000 who probably aren't, if not 200. So
we're not sure on our number.
Yeah.
Right. You want to be sure on your number because that is the one thing that there's a bunch of stupid privacy laws that prevent drug companies and anyone else really from getting into that number. But we as patient advocates can talk about ourselves. And that's like one of our powers. So I would, like the 2 things I've done that I think are smartest and I would say that anybody can cost very little are make your own cell line and own your number.
Yeah, because I mean, my son was the 76th diagnosed, and I pretty much knew everybody at that point, and then we kept growing. Mike came in 18, and I mean, it was serendipitous that Mike's like, we need to really nail this down, like where everybody is at, because we could connect like, oh, if we're going to do a clinical trial at this location, we like know how many patients are in that geographical area. And so it was very foresight that we were able to really pull that together so we would know when we were to get to a clinical trial and we were to set up clinical trial locations, then...
Or just forget clinical trial studies. Like we're funding a study with Harvard right now. They wanted 20 patients. We gave them 10 in Boston. They want 10 in LA, and then they just lowered the age on us to capping it at 11. And they said, how many patients do you have? 2 to 11 on the West Coast. And I can answer that. I'm like, not really. Like most of my patients on the West Coast, oddly, are older, right? So like before we talk about clinical trials because that's what we all want. But before you do clinical trials, you're going to be recruiting for studies, and that's another muscle that as patient advocates we need to. Like, those are very important. You need to find the patients, and maybe one of you or both of you are the parents who can pick up the phone and talk other parents into doing these things. Because I wave that in front of drug companies. I filled X studies, right? And we can do that. And that's really having a list. And don't get a registry and don't pay anyone money like I'm talking about an Excel spreadsheet. Have your own list and build it up.
Yeah.
You need a registry eventually, but a lot of people, oh, HIPAA, I can't collect any data. Bullshit, right? You're a parent, you know other parents. Build the list.
Yeah.
And then over time, you will find someone who will help you build a better registry, which you wanted to ask me about.
I think that's where the role bleeds over from social connector into registry. Yeah. I think one of your greatest positions, and the reason why I would consider you a force of nature in this field, is you leverage that power of social connection. What all these communities ultimately need to do is, regardless of whether or not you have a cell line, or whether you've categorized all the people in your group, it's just the fact that you're finding patients, you're out there finding people. What the ICD-10 coding system is not doing, what individual hospital medical centers, no matter how wide their network is, can't do on a worldwide scale, or even each healthcare system in each individual country can't do. You have a worldwide reach. You're leveraging any tool that's low cost and wide reach, like Facebook, and finding these patients, plugging them into the community, and having these conversations in a space that's safe enough for people to share information, right? If Biogen creates a website for you to register on it, that's not safe because it's just one company and it's a for-profit entity. But as a nonprofit, and especially as a parent, you instantly have that credibility and can bring more mature conversations to the table.
Yeah, and getting genetic testing is not easy. So again, Mike, it's all about probably genetics. So how do you do more of a low-cost strategy to get information out to, again, 0.5 to 1% of intellectual disability is Syngap. So we know we're underdiagnosed heavily. So the question is can we target, intellectual disability communities and say, hey, here's probably genetic. You can do this quick answer question stuff, and it'll tell you, what your probabilities would be for having SYNGAP1. So that's a really low-cost area, and then it's a recommendation to try to get you into genetic testing. And so we're really reaching out because we would say, we know we're underdiagnosed, and we would say we're really heavily undiagnosed in minority populations. In the Black community, Hispanic communities, we know there's healthcare disparities that are happening in the United States, that they're not getting the same level of care that many of us that are heavily educated to be able to know what questions to ask of their clinicians and are not dismissed and advocating for themselves to be able to say, I know there's something going with my kid. He has pervasive developmental delays. He has seizures that are happening as a toddler. He may have an autism diagnosis or not. But because he has all of this heavy comorbidity diagnoses, it 100% makes sense in today's medical environment that a genetic panel should be done. Is it a whole exome? There's a lot of debate on that. But at least you can start off with a targeted panel within pervasive developmental delays, or with an epilepsy or autism. Syngap is going to be on all of them. And again, companies are always changing based on the literature and identifying new genes to get them onto panels. So then you go back, can that be reanalyzed in order for me to be able to tell? But again, a lot of families don't know, and this kind of a conference helps to be able to advocate and talk to families about that. But we have so much work to do in order to be able to find the patients that are out there that we know. In California, we have less than 25. That's ridiculous, and we should be several hundred. We have so many programs that should be available to be able to get the diagnosis through genetic testing, and we can't.
It's really hard. And it's harder, I think, for us because our seizures come on so slowly as Syngapians. Whereas you guys, unfortunately, KCNT1, it'd be hard for a doctor to miss the seizures, right? Like, they shouldn't be a doctor. Yeah. So it's a different world. But I do think, thank you for what you said. I think I started spending a lot of money on science. And now, like, that machine is just built. We raise money, we give grants, blah, blah, blah. Like, the thing I spend my day on right now is outreach, connecting with patients, encouraging people to get diagnosed. And by the way, I sound silly when I say this, but like a year and a half ago, my wife looks at me and she was like, dude, you're kind of a jerk. She's like, I love you, I married you, but you're kind of a jerk. And people think you're a jerk. And you're asking parents to sign up, to give you their data, to get ready for trials, to read your blogs, and you're a jerk. And so if people got to know you better, they wouldn't think you were a jerk and they'd do the things you asked them to do. And I was like, when does this talk end? And she said, you need to do videos. Like, you need to help people get to know you. And so I was like, oh, how do you make videos about yourself? Oh, a video podcast. So I started a video podcast. And my board was like, no, this is a terrible idea. Don't do this. Do not do this. Please don't. I said, let's just do a few. Ashley told me to, and then if they suck, we'll delete it. And if you Google Syngap1, you're going to very quickly find my podcast. And people listen to podcasts. And when I went down this rabbit hole, like today, like people our age Google things. Like kids, they TikTok things and they YouTube things, right? Video is actually where the next generation of parents of our patients are going to be. And so what I do every week is I manage to talk to a screen for 10 minutes and share something useful. And actually this week I talked about KCNT1 and the New York Times article and that ASO, because I got a lot of parents asking me, right? So I just Googled your organization. There's 5 people on your board. Like the organizations by definition get really down the rabbit hole of the diagnosed community. And one of the things I think about when I think about patient advocate groups is, have they forgotten that there's billions of people on Earth, and there's a lot of undiagnosed people, and they still need to let them know about your gene. Because you didn't know about your gene before your daughter was diagnosed, right? You didn't know about KCNT1. So who's doing the public engagement, right? And the cheapest way to get yourself on the internet is actually not building a website, it's starting a podcast. And you could talk about your daughter's story, and you've got 99 episodes if you just interview every family in your group. But as soon as you build that loop, people start calling you, people start asking questions, and then you realize that what you just said, you need 3 episodes to explain, right? What is genetic testing? What is a missense mutation? Why do we know that 9 people have this mutation? And so I would say what Dr. Nguyen said about, cost-effective community engagement, and I would say if you're a parent who's like, I don't know how I'm going to raise $1 million, don't. It's a pain in the ass to raise $1 million. But if you are sitting here and you're wearing the t-shirt and you're thinking about how am I going to help my daughter, you're going to help your daughter by making the community bigger. Because with 100 patients, you're smoking something if you really think a big biotech's going to come along and help you. I'm happy to be wrong about that. But if you had 1,000 or 10,000, it could be different. And there are patients right now on Earth who have your daughter's mutation, who have your daughter's gene on their report, and they haven't even thought to reach out. So, like, public engagement and putting yourself out there is actually a really smart thing to do. And I only did it by accident. But that podcast has, and it also, as an advocate, it saves me hours. Right? I did episode 80 today. Mm-hmm. That's 800 minutes of me talking, and for some reason, my families listen to it because they want news. Before that, I would spend weeks writing like really beautiful blogs with links to everything. Some of the links even worked. And nobody read them because they're really complicated and you have to sit and think. But anybody can like watch my podcast and then watch it again. And so that's something else I would advise advocates to really think about.
And
It's
the
powerful.
other thing we've done is we do webinars all the time, and we have, because then there's so many questions that people come up with. And one of our goals from very early on that we said is we could ask these questions a million times. A new family comes along, they're going to ask the exact same question every family's going to ask
Yes.
us. And so what we did is we created blogs that we would point to and say, hey, this blog talks about sleep issues, or if you know, et cetera. And so we've really worked hard to have a lot of resources to the family to point them to them so that they can get the answer, you know, from that information. But also connect with them personally and know what's happening in the community, because it's happening really, really fast. You may have 100 today. Again, in 2015, I mean, our gene was discovered in 1998. First patient wasn't diagnosed till 2008. And we weren't diagnosed until 2015. So, and we were the 76th patient. So that tells you how slow the process is. But again, we've been gaining with almost 1,200 where we are today. So you can see that progression. You may be where you are today, but in 10 years, you're going to be in a very different place. How you organize now is so, so important.
And she's 2.
She's 5.
She's 5. So when before she's even, you know, before her sweet 16, you have 10 years. The world's going to change in 10 years. And
Yeah.
if your organization doesn't have a podcast yet, start it. Because it's crazy how fast we've gone from being a small rare disease. Literally, when I was diagnosed 4 years ago, and we very fortunate, very connected, called a lot of people, and we got pat on the head by a lot of important people who were like, look, they're going to cure Dravet first, and then after Dravet, if you're lucky, they'll cure Syngap 1. But wait for Dravet. And then 6 months later, Stoke announced their ASO work on Dravet, and then 2 years later, I started getting phone calls from biotechs who were like, Dravet's getting crowded. A lot of people working on Dravet. What else is out there? You know? And that's going to happen. Probably KCNT1 before KCNA2, but people are starting to look at these things, and the fact that you're already diagnosed and there's already 100 patients means that in a few years there'll be 1,000 patients. And the real power is not if you've raised X million dollars and funded so much science. The real power is if you're the person who can call 20 patients and get them to sign up for a trial.
And also, your potassium channel.
And then
right?
we're done.
Right. So there's a whole collaboration of potassium channel stuff, right? So one of the smartest things you can do is create a consortium or a collaboration between potassium channels. You know, and again, you may be right. I mean, so there's so many opportunities on how you can approach this. We would look at synaptopathies as looking at who are other like genes that we can collaborate with. I think is another really smart way to look at how you optimize your resources when you're looking at like for like and you're working within sort of, I think, potassium channels or other like disorders would be really a really smart way of kind of looking at it.
Own your gene and then
right?
and then broaden. Yeah. But anyway, thank you guys for sitting in here and listening to two dads babble for an hour. That's our hour. I think we did great.
Yeah, I think we do.